Let's do it.
All right, y'all. Welcome to the MMOA podcast brought to you by the Institute of Clinical Excellence. My name is Dustin Jones, one of the lead faculty within the MMOA division. And I have with me a very special guest, Jenna Muri-Rosenthal from Fit to Function. How are we doing, Jenna?
I'm doing awesome. Thanks for having me here.
Yeah. Thanks for meeting. So Jenna and I've been following you for quite some time on the gram, just seeing your awesome videos. We had a mutual friend, Julie Fouché, she said to me, you need to meet Jenna, you need to talk to her, just because you have a lot of really cool things going on, and just how you perceive how you can help people is very unique. And you're blending a lot of different worlds, which is pretty cool. So for the listeners that aren't aware of Jenna or don't follow her, well, first off, you need to. There's going to be a link to Fit to Function and all her social medias in the show notes of this podcast. But let's look at her bio really quick. So Jenna is a speech language pathologist and a certified brain injury specialist with over 10 years of experience in acute care and acute rehab, treating clients with cognitive communication needs at MGH and in the community. She is a CrossFit level 2 trainer. Congrats. That's awesome.
Thanks.
That's no joke. And a certified adaptive and inclusive trainer, and coaches classes and one-on-one sessions at Invictus Boston. And those that aren't too entrenched in the CrossFit space, that's a very well-known facility, very high-level athletes and all kinds of different types of folks are trained there, but that's a pretty big name if you're in the CrossFit space. Jenna has a master's degree in communication sciences and disorders and a certificate in adult teaching and learning from the MGH Institute of Health Professions, and is an adjunct professor in graduate SLP programs at MGH IHP at Northeastern University. My gosh, what do you not do? Yeah, seriously. My goodness.
You got it. Coming off.
Oh. All right. So I wanted to start here. I'm very curious because your career is very interesting to me, just from observing from afar. For you, what came first, the interest in functional fitness or the interest in communication, cognition, cognitive rehabs, becoming a speech language pathologist? Which one was kind of a first interest of you, kind of as your career was starting, as you were thinking about what you wanted to do with your life?
For me, it all started with speech and cognition. I can tell you sort of, I'll try to keep it short, but the winding road to how I got here. Like, I was a teacher, assistant teacher, and I was an athlete, and I kind of fumbled with what I wanted to do with work. Ended up working with folks on the autism spectrum, and encountered a speech therapist along the way, and was like, oh, cool, this is what I want to do. Went to grad school, got put into my adult placement, and I was sent to Spalding Rehabilitation Hospital on the brain injury unit with adults. And I was like, this is it. This is the thing that I want to do. And I fell in love, and I never looked back. And in all of my work in brain injury, the thing that was most significant to me was that idea of functional recovery, that sort of, how do we get people back to what matters to them, right? Because as a speech therapist, it's a lot of, there's functional tasks, but it's like, here's a worksheet. Let's work on your memory. Let's work on X, Y, Z. And it for me, really early on was like, well, how do I do things here that are important and meaningful to you? And in kind of you getting back to you. And then I found CrossFit about halfway into this career that I've had as a speech therapist. Got into it, kind of fell in love with it, hook, line, and sinker, just like anybody else, and very quickly wanted to coach, because I always say when we do rehab, like, speech and cognitive rehab is really, really hard. And you're asking really challenging things of people who struggle. And the gym is similar, but you have people who really want to be there. I was sort of like this, it's like it's a driven by goal, as opposed to coming to it from a place of struggle and recovery. And I was like, wow, there's some overlap here. And then when you think about CrossFit and its functional movements, and kind of how breaking them down into their components to build them back up again, that's a lot of what cognitive and linguistic rehabilitation is like. It's we take the most complex stuff, we strip it down, and then we build it back up. And so really quickly, I was like, these things align. That's like the career part of it. And I can keep talking, but let me know if you want to.
No, that's awesome. That's awesome. So the speech side came first, and then kind of getting into CrossFit and seeing those worlds collide.
Yeah.
Now, when you kind of started into the realm of CrossFit and functional fitness and drinking the Kool-Aid and all that fun stuff, what were some of the initial changes in your clinical practice that you saw? Like, what were some of those early like light bulb moments of like, oh my gosh, I may do this differently in the hospital as a result
Yeah.
of spending time in the fitness facility?
I think that a lot of folks don't necessarily know that speech, especially in like an acute rehab kind of setting, like it's all in, like OT, speech, we're all doing it, small team, you're moving people around, you're helping with the physical aspect as well.
Mhm.
And I think I started to just kind of identify what I was learning about the body and the way that it moved and how that could carry over kind of in hospital and in thinking about getting people home. And I started seeing, I'd always worked with a number of home speech clients, and I started seeing like, I want to use what I know about movement here with them, because I don't want to just sit at the table and do speech worksheets.
Mhm.
I want to think about how they navigate their home and how they can move their body better. And so it sort of just kind of like fell one into the other, where it started to become like, am I the speech therapist or the coach, or, sort
Yeah.
of like half doing what I know of PT, because, all those years working side by side, it's like, it just kind of started to merge into this one great, like big functional
Mm.
picture. And I started with these clients, I started just thinking like, I want to get them in the gym. I want these folks to move better, and do more than rehab has told them they can do.
Right, right.
Yeah.
So I can only imagine that probably some of your speech sessions were probably more I wouldn't say physically beneficial potentially than like the PT sessions. Like I could see your folks probably doing some things probably more challenging than what a lot of the
Yeah.
PTs may have been doing. That's something that we try and speak to a lot in this community is some of the unfortunate themes that we're seeing, and especially the settings that you practice in acute rehab, acute care, of just how we really handle folks with kid gloves when they could really be a challenge and a whole
Right.
another level to actually see some change.
Yeah.
But you're doing that.
Yeah. Yeah. I think too, and I've talked about this a lot before and written about it, is that like, we want to, a little bit in rehab and in the hospital, we kind of like want to wrap you in bubble wrap. It's all about safety, right?
Mm,
You get people moving again, but you don't want them to fall, and you want them to do it under supervision. And we teach them very strictly how to move with their new hemiparesis, for example, how to be safe. And the real gap in care is sort of, how do we then bridge them to greater independence and how to get out of unsafe situations?
mhm.
So, in my practice in the gym, in the first session for every client, I say, okay, show me how you get down to the floor. And they're like,
Mm.
oh, I don't do that. 90% of the folks who have come through the door have been like, that's not safe, I don't do that. And it's like, well, yes, but at some point in your recovery from a stroke, for example, you might fall,
Yeah.
or you might need to get something off the ground or get down up off the ground. So how do we do that safely? But I think there's a big gap there. And I love my PT and OT colleagues. Like, I
Mhm.
came a long way in the rehab process through them, but I think as a system, there's a gap.
Yes. Yeah. 100%. 100%.
Yeah.
So when you started to get into coaching, right? So were you coaching kind of the regular classes initially, and then were you starting to do some like one-on-one sessions, more kind of cognitive rehab type stuff? Did that come after you already coaching regular classes?
I was already doing one-on-one just speech therapy with
Okay.
individuals. Like, over the years, I've always had like 1 to 2 to 3 clients who are just looking for a little bit more in speech, because speech is like the least well reimbursed by insurance, and often folks run out of coverage of
Yeah.
speech before they run out for other. So I've almost over the years have always had clients that just wanted speech therapy. And then the idea, it was always, once I got into CrossFit, I always sort of had this dream of blending the two. And then I had 2 private speech clients who I was like, can I bring you into the gym and just try? And at the time I was like a budding level 1. Like, I didn't really know what I was doing, but I was like, let's just see how this goes. And,
Yeah.
fortunately I already had a relationship with these folks. And then sort of synced up with a former elite CrossFitter, Spencer Hendel, and he was willing to work with me with some folks, and we started to build a practice. And then COVID kind of shut everything down. So that's kind
Thanks,
of how we
COVID.
got here. Yeah, thanks COVID. I had like 5 clients and 1 coming, and I was like, we're doing it.
This
And
is
then I was
it.
like, oh no, that's it. And then that gym actually closed down during COVID because it just couldn't sustain. So
Yeah.
then we had the 2.0. That's where we're at now.
Right. Yeah. I feel your pain there on the
Yeah.
Stronger Life side of things.
Thanks, COVID.
Yeah. So when you were first starting to coach, getting in front of folks and being able to create this experience for groups of people, what things did you have as a speech language pathologist that made you a better coach? What principles or what things that are emphasized in your training really relate very well to coaching a class?
Yeah. I think understanding cueing and understanding sort of like the cueing hierarchies and the different like sort of learning needs, the different styles of people, that not everyone is going to respond to verbal or visual, and some people need a combination of all of the above, and the sort of ability to heavily scaffold something and then really pull it back step by step to build independence for an individual. I think there's a lot of carryover in how we help folks gain independence, because I always say it's like, if I'm helping you remember better, I can tell you exactly how to do it, or I can slowly give you a sort of incremental cues until you don't need anything from me. Or at least you know where to find the resources or how to compensate on your own. And so I think with coaching, it's very similar, right? Where it's like, I can come over and give you 10 cues and exactly how to do it. Or I can start to be like, what's missing? Okay, let's take a look here. And I think that hierarchy of cueing and the sort of like a handing over of the responsibility is what there's a big crossover there.
Mm-hmm. And I
said
to
this,
do that
yeah,
in
go
a
ahead.
group, like,
yeah.
Not just a one-on-one session, but to be able to work a room like that, that's impressive,
right?
To be able to do.
And thanks. And I think understanding learning styles, I'm also a professor, and I think that goes hand in hand with speech. But being attuned to the fact that not everybody learns the same way, and that you need to be able to, like you said, read the room and kind of know like who needs to see this, who needs to hear this, who needs a little bit of both, who needs it right up front, and who can just kind of hack it on their own. Yeah.
That's awesome. So in your experience, back to kind of the rehab clinical side of things, because I'm very intrigued with your line of work and how, especially the cueing, the communication, also like challenging cognition as well in speech, and just really layering things on in your sessions. I think that's an area from the physical therapy side of things we struggle tremendously. Like I think I have a lot of experience in home health and worked a lot with speech language pathologists and OTs, CODAs as well. And I feel like the OTs, y'all speech language pathologists, you have a lot of that stuff down and you receive a lot of training. It's a lot of your focus. The PT side of things, not so much, but we're starting to really see the value of that, of being able to blend some of those principles into our sessions as well. From your perspective, when you're doing acute care, when you're in acute rehab, and a lot of these places, you're maybe not acute care, but acute rehab, you're probably in a gym, you're seeing what the PTs are doing, what they're not doing. What are some of the most common mistakes or things that you'll see PTs, and we don't have to call any of your colleagues out, right? Like PT at large, what things do you see they struggle with that they could do better quickly, like low-hanging fruit?
I think as a rehab professional in general, we have a tendency to tell what to do step by step by step. It's kind of ingrained to say, do this, do this, do this. And I think the easiest thing is to consider how to take that down stepwise and sort of back off your cueing. If you want someone to go up the little fake stairs in the gym, and whatever the cues you're working on, maybe it's holding onto the railing. It's like, instead of saying, I want you to do this, this, and this, it's sort of like, what do we do first? Okay, then what? And if they don't know verbally, it's sort of like a gestural cue. It's kind of like incorporating all the different ways that we cue. You can tell someone, you can show them, or you can demonstrate, or you can hand over hand, but you can also dial those things down, right? Like if I want you to hold the handrail, I can sort of look at it expectantly and see if you can connect those pieces, right? It's that sort of dialing down from, let me tell you how to do it, to how can I like get you there as close as possible, because the more that you can identify what you need to do yourself, the better you will learn it. If
I love
that makes
that.
sense.
Yeah, it does. Cause I feel like and I'll speak for myself. but I've seen it a good bit too in different places I've been, where we are so quick to almost do the work for folks
Right.
instead of give them the opportunity to actively pursue that. It from the PT side of things, the relatable factor, I think, is when we provide assistance for folks, like physical assistance. We're quick to almost provide too much and not let people
Yeah.
struggle a little bit. If someone's like a max assist or whatever, we may assume
Yeah.
all their max assists versus, well, what if they were probably a mod and they're going to
Right.
work a little bit harder and probably get more benefit from it. This is
Right.
very similar.
Right.
It-
And it's the same with cognition and language, right? Where like people will, we can, the most concrete, easy example is you give a lot, you've probably seen a memory book. Most folks have probably seen, if you worked with a brain injury individual, here's your memory book, right? And when I provide it to an individual, I say, here's your book, turn to page 1, point to the time. This is how you know what you did this hour, right? But as you start to train, you sort of say, where can you find that information? And let them grab the book. And maybe they grab the book and they're lost. And so I flip to the page for them and I maybe just point and then they can locate it. And then maybe in another week's time, and I'm like, where do you find it? And they don't know. And I just kind of look towards the book and then they grab it, they open it, they find it, right? And so it's all about just kind of dialing, I keep saying this, I feel the same thing, but kind of just pulling back on the cueing. It's like, just letting people do some of the learning on their own. And as all clinicians, that requires us to step back a little bit and be a little more patient and just wait that extra second to let someone think it through, show us that they know it, or move in a way that we aren't supporting them so much, because they probably can do a little bit more than we think.
Yeah. And that stepping back can be tough. The
Definitely.
awkward pauses, just
you
waiting.
have to get real comfortable with silence and patience and not a lot of movement. You gotta kind of just have to sit quietly.
Yeah. That's can be very challenging. So what about the other direction of cognitive demand? Like, what if we're trying to, I shouldn't say other direction, but what if we're trying to really scale up the cognitive demand of our sessions? And I think you're doing this really well, especially with Fit to Function, of blending that kind of functional fitness side, but then also challenging the cognitive piece as well. I think that's a huge opportunity for a lot of PTs that are going to watch this or listen to this, working with folks that may have some type of mild cognitive impairment, some type of diagnosis, or someone that doesn't have any of that they just want to continue to build that cognitive reserve or maintain that cognitive reserve. How do you think about leveling things up from the cognitive demand standpoint?
I think what I say to folks a lot too, what's really cool is that about working with language and cognition is that they're literally everywhere in everything that we do, right? So you have the opportunity within any session, be it in the gym or PT or in a clinic, to layer the approach a little. So if you think about from a language perspective, it can be as simple as, rather than just giving a 1-step command, give 2, right? And see if the individual can follow 2 steps. And if it's language, can they understand the complexity? But if it might be memory, and it might be, will they remember these 2 things or 3 things that I've asked of them? I think depending on if there's some sort of cognitive impairment or like a mild cognitive impairment, you can start to embed some of the compensatory strategies that help people be more independent, right? You might have someone who won't always remember what you ask of them in the session, but they will remember to look at something that's written down for them. And that's a strategy that will give them carryover to greater independence. And I always say to people, I don't care if you remember, but if you know where to look for the information, that's as good as remembering. And that's really important for our older adults, right? Because so many people go, I'm old, I don't remember anything. But eventually we'll all have challenges, and we all use our calendars and our planners and our notepads for things like that. So why not embed that into everyday activities so that it becomes more routine?
I like that.
Yeah. And then, on a more fun level within a gym or a PT session or an OT session, like you can always add, say like, if you look in the newspaper, not that a lot of folks do that anymore, but, we have our crossword puzzles and our Sudokus and all of those things, all of those brain games are to help build cognition, right? So why not do mental math in the midst of the session? Tell me what 47 plus 68 is. I actually can't answer that because I'm a speech therapist. I don't do math. But like you can play word games. You can do all kinds of things to work on thinking. That's what all those puzzles are for.
Yeah, that's awesome. There's a very telling moment at the weekend courses we'll teach. We'll go through the mini best test, which has a cognitive dual task tug or timed up and go.
Mhm.
And you'll get someone's standard tug time, normal walking speed. They do that. And then you have them do a normal tug, but you have them count backwards, by 7 from whatever number that you count out. And I think, is it more than like a 10 if they slow down in terms of their speed, or they basically stop, or if I think like something super small, like a 10% difference in time, then that cues you in that this person has a difficult time with dual task and a cognitive dual task. And the vast majority of clinicians, we put them through this and
they can't do it.
Yeah, they can't do it. And that was very eye-opening to me. And I've felt this as well, just when I've thought about some of these cognitive demands under physical stress. It's a whole nother ball game. That even our patients, I mean, they're going to really experience that stressor, which if folks have not played around with that, it will be very eye-opening.
Right. It's like, I always joke too, like there used to be gyms that would do like trivia, like WOD night trivias, where you like put people through a round of something and ask them questions, and people say the most ridiculous things, right? Because it is really hard to dual task and to think when you've elevated your heart rate. And I think I use these kinds of things in the gym, and I think there are, I have some clients where we're just really working on that independence with knowing what they're doing in a workout and knowing what comes next and like marking off their rounds, right? And it seems simple, but it's not if you have a cognitive impairment. And for some folks, maybe they lose a few seconds in each rounds of their fitness, but I will allow that extra time to be like, what comes next? Where do you look? Think it through. What is a squat, or whatever that is? And maybe they lose a little in terms of the exercise, but what they're gaining in the ability to think it through, find the information, and gain some independence with cognition is worth it, as far as I'm concerned.
Yeah, 100%. That's awesome. So I want to shift gears a little bit and speak to, I mean, it's a related area, kind of different, but something that I really want to highlight to the MMA community, and the adaptive athlete and the evolution of the adaptive athlete's representation and participation in the sport of CrossFit. That I know you were recently at a really popular CrossFit event called Wadapalooza down in Miami, and with a few different athletes. Could you speak to the MMA community that may not be familiar with the changes that have been happening in terms of representation, participation, in terms of what you saw down there in Miami?
Adaptive CrossFit has been around for a while. WheelWAD, who is an organization that does adaptive programming, for example, has been around, I think, for like 12 or 13 years. And they put out programming for different limitations, different impairments, different groups of athletes. And over the years, they've sort of edged their way into different competitive spaces. And last year, for the first time ever, CrossFit as an organization recognized adaptive and brought them into the competitive season by having an adaptive CrossFit Open and having an adaptive division at the games. Now, that being said, I think all told, there are 16 current divisions for adaptive athletes. It's upper and lower, and there's intellectual division, and then there's neuro, and there's short stature, and there's seated with hip function, seated without hip function. There's a wide range. And as far as representation, CrossFit hosted at the CrossFit Games, they hosted upper impairment, lower impairment, and neuromuscular as categories. Which is a good start. Obviously, the adaptive community is seeking more. And there are a lot of adaptive athletes out there. There are, like I said, a lot of different groups. And I think one of the major challenges is that there's not enough of them. Each group doesn't have quite a big enough representation yet to have a competitive pool. So at Wadapalooza, we had an adaptive side of the competition. It was excellent. But on stage, you had, in heats, you had a range of like upper extremity impairment, visual impairment, and short stature. Like you kind of had a mixed group sort of competing against each other, but also for some of the groups competing really just with one or two other individuals, because there's just the pool of adaptive athletes who want to do CrossFit competitively, I don't think has grown to the extent that we need it to as yet. But it's on the rise, which is great.
Yeah. And you have some awesome posts on your Instagram feed that will highlight a lot of this stuff. But I encourage for folks listening or watching that when you start to learn more about this space, particularly the adaptive athletes in the realm of CrossFit, you will learn a ton and gain a ton of ideas to use with a lot of your clients. So different tools that are available to adapt for different impairments. And a lot of these impairments we're seeing on a day-to-day basis in the context of rehab. And that's been really eye-opening for me in terms of, well, what is possible, but then also the some of the equipment that you can get to adapt different pieces of traditional fitness equipment, if you will. So it is accessible to a lot of folks. There's just a lot from the PT side, like, man, there's so many ideas that folks can get from consuming a lot of that material.
And I think too, it's like what I have found in my practice is that it's a layering of approaches, right? Like a lot of the things that are actually movement patterns that are prescribed or designed for single arm or single leg or seated, if you combine all of those together, then you have the perfect exercise for someone who has hemiparesis and maybe can stand, but maybe only has one good functional arm, and maybe you're worried about their balance. Okay, well, look, you can sit and you can do a single arm clean and jerk with a dumbbell. And I think, like you said, it's like they all just sort of layer together. And I get a lot of my ideas from social media too. I just see what other adaptive athletes are doing, because even in things like the upper extremity, and you've got such different like levels of points of contact. So some people don't have any, residual limb here to hold with, but some people have through the elbow. And so you can also see different ways that things are modified based on individual limitations as well.
Yeah, and I think even the folks that may be watching or listening to this that mainly be in like outpatient orthopedics, for example, lots of ideas from that standpoint. If, let's say, irritability, pain is a limiting factor for someone, that a lot of these same adaptations you can use to continue to get people fit, even in the presence of just pain. I just feel like it's so applicable to so many folks. So, but thank you for highlighting that. Your feed is like gold with a lot of those.
Oh, thank you so much. Ideas. Yeah. And what's cool, I just put up a post yesterday about like a friend who sprained an ankle and was like, well, I can't go to the gym. And it's like adaptive and inclusive training is so cool because you can modify, like you can keep anyone in the gym with the sort of right creative approach. And I love that for it. Like over the last year or so, it's like, oh, I hurt my wrist. I'm like, oh, well, let me give you some single arm exercises you can do, and I think we have in regular standard gym CrossFit, we have some kind of like, oh, okay, well, if you can't use both arms, use a dumbbell. But like there's more, it goes above and beyond, right? We have more creative approaches to that. So I think it's fun.
100%. My dream is that the gyms in the acute rehab, the PT gyms, the rehab gyms will have a lot of that equipment in there. Because
get a squat rack in there and
right. Awesome. All right. Well, I appreciate you, Jenna, just sharing your passion with the world, your Instagram feed. I'm grateful for that. Great.
Thanks. Thank you.
Sharing your information with us and some helpful tips that I think a lot of people will chew on in terms of how they can kind of inject some of the things that you're doing on a daily basis into our session. So I do want, would you mind saying your URL, your website URL, and your Instagram handle if people want to find you?
Yeah, my website is fit2functionrecovery.com. TO, not the letter 2. And then my Instagram is fit2functionrecovery. But that's
awesome.
That's my Instagram is more informative than my website, I will say. That tends to drive people. So. Hit me up, follow me, send me things, ask me questions. I love doing this stuff. I love helping. I love seeing other people blend creative approaches. So I'm here to help.
Yeah, sweet. Awesome. Well, grateful for you and sharing all that stuff. And folks, I'll have links to that in the show notes for the podcast as well, so you can find that.
Cool.
Awesome. Appreciate it.
Awesome. Yeah. Right. Thanks for having me.
Yeah.
Thanks, everyone.
Yeah.